Okay, it's exactly 1 o'clock. We'll give it another 10-15 seconds for participants to join the webinar, and we will get started. Welcome to our webinar today, CYC Guideline 6, Medical Evaluation and Treatment. Our presenters today are Dr. Amy Orenstein, Medical Director of the IWK Health Center, and Tanya Smith, Co-Director of the Suspected Child Abuse and Neglect Program at Sick Kids Hospital. I will start today's webinar with a land acknowledgement for Boost CYC. Please consider the land on which you reside. Boost CYC is situated upon traditional territories. The territories include the Wendat and Anishinaabe Nations, the Haudenosaunee Confederacy, and the Mississaugas of the New Credit First Nations, who have been the traditional caretakers of the land for thousands of years. Toronto is in the Dish with One Spoon territory, which is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. Please note, we will have a short Q&A period at the end of the webinar. There is a possibility not all questions will be answered. If you would like to contact the facilitators, their contact information will be included in the chat box. If you have any questions, please post them in the Q&A box. All other inquiries can be included in the chat box. This webinar is being recorded in both English and French. The English and French PDF for the slides were included in this morning's reminder. The link to this webinar will also be posted on our YouTube channel within a week. And with that, I am going to transfer it over to Tanya.
Thank you, Atika. So welcome, everyone. We are going to spend probably the next 45-50 minutes just talking about the National Guideline number 6, which is focusing on medical evaluation and treatment. And our goal for today is really to outline some of the important aspects of this guideline, and to also give you a few case examples to sort of highlight the role of the medical evaluation within a CYC and what that would typically look like. I can anticipate that many of you are not medical providers, and so our hope today is really to give you a better understanding of what the role would look like, the types of patients that are being seen, and then how the medical program will best fit within and with a CYC. So just a small disclaimer, we obviously, when we're talking about the medical evaluation of children who've experienced physical and or sexual abuse, this material is quite sensitive in nature. And so we did want to give you a heads up that sensitive material will be discussed throughout this webinar. In addition, we will be showing images of children who have sustained injuries. They will be a bit graphic, and the reason we're showing the images is to really, it really helps to better visualize the types of cases and the importance of the role of the medical provider in these cases, and helps to outline what exactly a medical provider can do in these cases with respect to providing an opinion and with respect to the importance of photo documentation. I really do encourage you not to take any screenshots of our slides or the images, and I do understand that there will be a recording and a handout available to you with the content. So when we look at the guideline number 6, which is focused on medical evaluation of treatment, this is really sort of highlighting the importance of the medical evaluation, and that a medical evaluation be made available to all children and youth who come through a CYC, and that it be coordinated with a multidisciplinary team response. Now, this may sound fairly straightforward, but there are many aspects that we have to consider when we do offer this kind of an evaluation for children and youth. Really, we have to remember what the goal is of the medical evaluation. And first and foremost, it is really to reassure children and families about the child's well-being. And secondly, obviously, is to identify and document any necessary medical findings. We want to screen for injuries and medical conditions, and then obviously initiate any treatment when necessary. Some of the big questions I often, and Dr. Ornstein and I get when people are looking at developing a CAC in their community or partnering with a medical provider or hospital to deliver services is, should they have a medical clinic or a medical examination room embedded in the CYC if it isn't a hospital-based program? And the answer to that is not very concrete, and that it really does depend on your community and your community's needs. It also depends on who the medical provider or medical team that you will be partnering with and where they are located with respect to your CAC. Many CACs do not have a medical clinic embedded within the CYC, and that is totally acceptable and understandable, and may not even have medical providers sitting at a CYC. But what is really important is the goal to obtain partnership with either a medical provider or a medical team who can be a consultant, who can triage cases, and really maybe provide a gateway into medical services within your community. This may be someone based out of a hospital. It may be a practitioner who runs a clinic in the community. So it really does require sort of a good understanding of who is in your community from a medical perspective point of view. And we're going to talk about who these individuals should be and what their training should look like. So it really is something that will vary from model to model, depends on where you are in terms of your stage of development. And it also will depend on the types of service that you're going to provide. And what I mean by that is determining what kinds of medical services will be offered at your CAC. When you look historically at CAC development, especially in the US, a lot of it was based on the services for sexual abuse investigations. And that has really expanded over the past many years to include physical abuse cases as well. So you want to be able to understand, is your CAC going to be servicing all types of abuse, just sexual abuse, just physical abuse, both? And then who are the providers that are going to be able to, provide evaluation for both of those types of presentations. You do want to be able to think about consultation regarding the need and timing for an exam, and I'm going to talk about that as well in a little bit. There may be an opportunity to link with your child protection agency. Some child protection agencies partner with CAC medical providers to be able to provide an intake medical assessment when they may be taking a child into a place of safety. And if there are no medical providers available, that this could be an opportunity for a medical provider at a CYC to take on this role. Again, just to reiterate that medical services can be provided at a CYC, co-located, or they can also have a strong partnership with a hospital-based child protection team or a child protection provider in the community. So within the guideline, there are sort of 8 aspects that I'm going to just sort of run through today, just to highlight some important principles that should be offered and addressed within your CAC. The first one is that the medical, excuse me, medical evaluation should be offered to children as determined by medical clinicians or the local multidisciplinary team. A medical evaluation can include many aspects. Primarily, as I said earlier, is really to provide reassurance to children, youth, and their families. But the other big role that medical providers play is to assess, manage, and document injuries. In the cases of sexual abuse primarily, we are testing for infections, we're collecting forensic evidence, and we may even need to provide necessary medications and/or treatment. So this is sort of the broad scope of what medical evaluation would entail. The second principle is consultation with the multidisciplinary team to allow for decision-making regarding scheduling of when an examination should occur. So what needs to be remembered is that not all cases need an exam immediately. And so a big part of the medical provider role and the medical evaluation is having a conversation with the team, medical team, and the multidisciplinary team to determine where the exam should take place, who should examine the child, and when the exam should take place. One needs to distinguish how urgent the exam is needed versus a less urgent exam, which could be better coordinated with the multidisciplinary team, sometimes co-located at the CAC. There's various expert clinicians who could provide a medical evaluation at the CYC, but it's really important that those providers and those clinicians are quite, that they're a distinguished group in that as experts, we really need to make sure that they have the proper training and ongoing continuing education. So when we're talking about medical evaluation when it comes to physical abuse and neglect, the individuals who are best to provide this service are physicians. The work that is being done within the physician's scope of practice is quite extensive and will require extensive medical training and medical background to be able to provide opinions when it comes to injuries of children. And we're going to talk about training and what is the level of training that's needed for physicians. We also need to think about those who are providing opinions for children who have experienced sexual abuse. The scope of practice is a bit, more limited in sexual abuse. And so we can think about having physicians, nurse practitioners, registered nurses, or sexual assault nurse examiners with a pediatric focus. And the reason that this type of service can have a broader provider group is because the opinions are much more narrow in scope and do not require a much broader understanding of injury and different types of injury. And therefore, it falls within a nurse's scope of practice to be able to provide opinions. What goes beyond sort of this talk is distinguishing between expert providers and non-expert providers in your community. Expert clinicians are ones who have a certain high level of training in the area of child abuse. That doesn't mean that you always have to obtain an expert in your community. But it's really important that if you do have a medical provider in your community, that they have access to an expert clinician, typically in a bigger city with a pediatric center or a hospital with a big pediatric group, to access an expert clinician for second opinions or clinical support. In order for good medical consultation to occur within the CAC, what should be a very important standard of practice is photo documentation. Photo documentation is really key because it helps to obviously document examination findings, which will help to enhance the process of consultation. It enables peer review to allow for clinicians to review each other's cases and build consensus. It's important from a quality improvement point of view. In the field of sexual abuse, genophoto documentation is a standard of practice. The use of photos really does, though, need to be thoughtfully thought through, in that you not only just need to be able to find a camera that fits your needs, but you also need to address issues around obtaining consent from children and families to take their photos, how you're going to store the photos, and therefore how you're going to access those photos. So while photo documentation is a standard of practice, there's a fair amount of processes that need to be put in place in order for this to occur. Medical clinicians should have adequate training, ongoing educational support, and access to up-to-date equipment. In the area of physical abuse, as I previously talked about, this is really the main role of physicians to take on as providers in this area. Many pediatricians in particular will have had some sort of added training. Most recently, the Royal College of Physicians and Surgeons has put in place a formal training program, and there is a formal training program for pediatricians to complete a 2-year fellowship program after their pediatric residency. And this does provide you a pathway with a very specialized fellowship in the area of child abuse. In addition, within Canada, there is a yearly symposium which pulls together all physicians across the country to be able to review best practices, talk about new literature. And so it's a really important network of clinicians to support each other in the field. There are many other conferences available for physicians to obtain sort of ongoing continuing education. Another conference that is available in the US is the Helfer Conference, which many physicians do attend. In the area of sexual abuse, the training does vary across the country. There may be some basic sexual abuse training that may be offered provincially for nurses and physicians. There is a formal national course that is run out of the BCIT program. So that's the British Columbia Institute of Technology program. That's run every other year. There are conferences held by the International Association of Forensic Nurses. And again, we also run a sexual abuse training day through the National Symposium. So these are sort of just examples of various training opportunities that are available to medical providers who are practicing in the area of child maltreatment. One of the important aspects of providing care for children in this field is to ensure that there's access to established experts for second opinion when needed. In addition, that there's ongoing peer review of cases. And peer review of cases involves reviewing images or photo documentation. It could involve reviewing certain medical investigations like x-rays, blood work. It could also include reviewing reports that were generated following the examination, court transcripts that when clinicians testify in court, a review of those transcripts can also be very valuable. And that there's also a really important process for discrepancies in opinion. So whether that be if a peer review process was to take place and there was different opinions that were presented, that there's a process by which you can access an external provider to maybe be a third party to help to address a discrepancy in opinion. So all of these are really important processes to put in place that most of us as medical providers will ensure that we have enacted in our settings. All staff at a CAC and all members of the multidisciplinary team should all be trained about the nature and purpose of the medical evaluation. And this is really important to minimize anxiety and enhance comprehension, especially amongst the children, youth, and families that we see. So important things or statements like the medical examination is non-traumatic and it's meant to reassure you and your child that everything looks okay are really important statements that all staff at the CYC should really understand. And we're going to walk you through a few cases to help provide some context for some of these statements. Things like we will, the medical provider will be conducting a head-to-toe exam, but we will be focusing on the vaginal, penile, and anal area. That it will not be an internal examination. And then when we're talking about photo documentation, things like I would like to take pictures of the marks we see on your skin with your permission. So statements like these are very common and ones that we use in our practice all the time. But it's really helpful, I think, for non-medical providers to understand how a lot of these things are articulated so that can be reinforced when meeting with families as well. And finally, conducting the medical evaluation is one aspect. But in these types of cases, what is really important, obviously, are the findings and the examination findings, and how those findings are communicated to the multidisciplinary team is really key. And so there needs to be a really good understanding within a CAC about how findings are shared, but in the context of understanding the consent and the sharing of information. So sharing of information should be established obviously as early as possible in an investigation, including medical providers who would be able to share the findings of their examination. So here are two sort of examples of the types of opinions that are often generated from a medical evaluation of both sexual and physical abuse. So the genital findings are normal and therefore neither confirm nor refute sexual contact. Or in a physical abuse case, bruising is most commonly the result of traumatic injury to the skin and occurs when there is damage to underlying blood vessels, causing blood to leak into the surrounding tissue. So you can read from this slide that there is quite a detailed opinion that is often generated from a medical evaluation. And it's really important that there's a clear communication process between the medical provider and the multidisciplinary team to ensure that the opinions are clearly communicated and clearly understood for investigators to determine next steps. So just in summary of the 8 principles, when we're thinking about medical evaluation, one of the things we always really encourage the CYC to really think about as part of a multidisciplinary team approach is to always call the medical provider or medical team prior to sending a child to a hospital or to a clinic, because we may be able to better think about where the best place or when is the best time to see a child. As you all know, right now, there's significant pressure on the pediatric hospital system. And so when it comes to times like this, we want to ensure that we're sending children to the right place at the right time. So if a child can be seen during the day in a clinic by a medical provider in your community, that is ultimately going to be the best place for them to be seen. Going to an emergency department and seeing an emergency physician is not going to be helpful, obviously, unless the child needs immediate medical care. But often you will get an emergency physician who may not actually feel comfortable or have the expertise to provide an opinion around injuries. The emergency department tends to be sort of a less trauma-informed setting, and they may be less aware of the process with respect to the medical and legal nature of the case. So it's really encouraged that developing close partnerships when it comes to triaging and consulting with your medical provider at your CIC is really key. So I'm going to talk really briefly about sexual abuse evaluations, and then Amy is going to pick up and talk about physical abuse cases and what they look like in a CAC type setting. So for children and youth who've experienced sexual abuse, what we have to remember, and what I've always really tried to encourage amongst the multidisciplinary team, is that regardless of when the sexual abuse occurred, regardless of what type of sexual abuse has occurred or the type of contact, children should always be offered an examination. Many times the multidisciplinary team or investigators will assume that because a sexual abuse event occurred weeks, months, years prior to the disclosure, that an exam may not be necessary. And while the forensic aspect of an exam may not be needed, what we do find is that children and youth and their caregivers may find value in having an exam to reassure them that they're okay. We have heard from many children and youth who've gone through their trauma treatment program, that an examination following a disclosure has really helped to reassure them that they look normal and they look okay. And that could be a really important aspect of their healing that should be offered to kids and families at any point during their journey. Many children and youth may have questions that stem from the assault, regardless of when the assault occurred or what the type of contact was. So they have questions like, am I a virgin? Or am I damaged? Or will someone be able to tell that I was assaulted? In addition, there may be physical exam findings that could be really important to the case. So in particular, there could be old healed injuries or injuries that may be indicative of trauma. Or there may be sexually transmitted infections like genital warts or chlamydia or other types of infections that would be really important for us to establish and could be really important to the investigation. Just from a general health point of view, maybe an opportunity for us to review their immunization status. For older youth, it may be appropriate to start some sexual health counseling. In addition, an examination, even though we know that the majority of examinations in children are normal, it's important that this is documented, and it is important that we're able to explain why the exam is normal. Because it's really important that all providers, as well as children and families, know that because there are no findings on the exam, it does not mean that the sexual abuse did not happen. This is a really important point that many people may not actually understand. And medical examination and opinion generated from that medical exam will help to clarify why we don't see findings on an exam. Often a final opinion that will be provided in a sexual abuse evaluation is that the general exam findings neither confirm nor refute the sexual abuse concerns. So very quickly, this is a 5-year-old girl who disclosed ongoing sexual abuse by her boyfriend, which occurred 6 weeks prior. So a typical sort of, aspect is that we may hear from clinicians in the community who do an exam following a sexual abuse disclosure and or have a finding or see something unusual. And in this case, it's an abnormally large opening with the hymen not intact. So this would be a really important case to involve a medical provider who's associated with the CAC to do a proper examination and to provide an opinion to investigators in terms of what the finding is. Most often what we find is that clinicians who don't have training in this field are overcalling or stating that there are findings when the exam is actually normal. So it's really important, again, that linking with a provider who has specialized training in this field can really help to clarify those opinions. And finally, a 12-year-old girl who has been sexually abused by her uncle 3 days prior. She may have experienced an interview at a CYC, which gave a full disclosure. And then the opportunity then would be to bring them down to a clinic through the CYC to receive pregnancy and HIV prophylaxis and evidence collection. So in these kinds of urgent situations, it's really difficult to offer a full-on medical exam in a CAC type clinic because of the need to access a variety of other treatment regimes such as prophylaxis. And so that is why linking with a hospital-based program is really key. An urgent call for a sexual abuse exam is really within 72 hours, where the need to collect forensic evidence is really key, and to address any symptoms of pain or bleeding, and to start on HIV prophylaxis or emergency contraception. Again, most of this can wait till the next day, and it's best done after the forensic interview. But again, this is where the initial consultation with the medical provider from the MDT team can help to sort out. So I'm going to pass it on to Dr. Ornstein, who will talk about bruising.
Thanks, Tanya. Are you able to advance the slide for me, please? Thank you. So I'm going to go through, as Tanya did, just start with an overview of the principles of how physical abuse assessments can be approached at a CAC. And I think it is important to go back to the point that Tanya made, that when we look historically at the purpose of CACs and CYACs, this process was started really to respond in a coordinated way to sexual abuse allegations. However, we have seen a bit of a shift in practice where probably over the last 5 to 10 years, many more centers are asking the question as to whether or not they can begin to see children who may have experienced physical abuse as well. So you might work in a center that's still in the contemplative stage of whether or not this is going to be part of your practice, or you may already be offering these types of services. So one of the main reasons to have a child seen is for documentation. This would be done perhaps using a body diagram, perhaps using photographs, as Tanya alluded to. An opinion would be generated at the end of the assessment, and factoring into that opinion would be whether or not there were any underlying medical conditions that may have contributed to any skin injury that we're seeing. We can also make a recommendation as to whether or not additional testing might be needed. For example, in very young children, we might be recommending that a skeletal survey be obtained, which is essentially x-rays of all the bones of the body. The child would need to be referred to a hospital that had capacity to do that testing. And similarly, we might be recommending head imaging to screen for any underlying traumatic injury to the brain, and also potentially an eye exam. And this is really in the group of very young children that we would be going through this decision-making process. We might also recommend laboratory testing to screen for things like abdominal trauma, if there was any bruising on the belly, for example, or if there was a history and we became aware that there was a bleeding propensity in that child or family, we would certainly need to think about whether or not a bleeding disorder could be at play in this particular case. And sometimes we come up with, because a lot of the clinicians that are doing this work are pediatricians by training. Sometimes we are able to identify other underlying, unmet medical needs in that particular child. And we also sometimes are able to coordinate follow-up, because if there are serious injuries, there could be long-term health implications for that child, which would need to be monitored. Next slide. So bruising typically is caused by trauma to the skin. There are blood vessels in the skin and underneath the skin in the connective tissue. And when there's force applied, there is injury to those vessels, and blood can leak out of the blood vessels, and that then will collect in the tissues and will be seen by an examiner as a bruise when we're looking at the skin. In kids who have a bleeding disorder, so something they may have been born with, a genetic condition that runs in their family, for example, they might bruise with less force. So they may even just sort of bump into something lightly and they might get a bruise, or even spontaneously in some situations. There are a number of medical conditions that can lead to spontaneous bleeding or bruising. Some of these can be acquired, so the child may not have had them all their life, but for example, if they've just have recovered from a viral illness, they may have post-viral low platelets, for example, which can then lead to spontaneous bruising. So something that the clinician would need to be asking the right questions for. Certain medications can also predispose individuals to bruising and bleeding more easily. And one point that comes up in the forensic nature of this work is whether or not clinicians are able to provide a timeline for when a bruise may have been acquired. And it's important to remember that we as clinicians are unable to date bruising based on the color alone. There are some other features of the bruising, such as potentially if there's some swelling associated with it or pain associated with it, that suggests that the bruising could be more recent. But based on the appearance and the colors that we see of the bruising alone, clinicians should not be giving you a very specific timeline as to when that bruise occurred. So during the investigation, one of the pieces of information that's very helpful is when was the last time the child was seen without the bruise, and then when was the first time the bruise was noted. And that's a bit of a way to recreate a timeline as we're working through these cases. Next slide. There are some red flags associated with bruising, and what we mean by this is really, when should you raise an eyebrow when you are seeing a bruise and hearing a story and something doesn't necessarily sort of ring true to you? So if we had to identify what's making you raise your eyebrow potentially, it might be things like the age or the developmental level of the child. So we have written there bruising in a non-ambulatory child, so really infants before they're on the go. It would be very unusual to see a bruise in this population, and it makes sense because a 3-month-old is pretty much living either in their bassinet, in someone's arms, in a stroller, and they aren't out doing all the things that an older child might be doing, like playing soccer, riding a bike. So it would be very surprising to see a bruise in a young baby who has limited mobility. A pattern is also something that we would identify as a red flag. And so you might look at the shape of a bruise and you might see a specific outline that calls to mind a handprint, for example, or an implement, for example, if there was an object that was used or involved, I should say, in the application of force. A pattern doesn't always mean that an injury was sustained in an inflicted way, because we could all probably call to mind when we've sustained a bruise that looks like a line or has a particular shape to it. And you might think, oh, that's when I banged my arm into the edge of the table and I ended up with a straight line mark across my arm. Or a child may have been hit with a ball, for example. If you think of a hard ball, like a lacrosse ball, that can certainly leave what looks like a pattern bruise on the child. But if it was sustained during a lacrosse game, it would not be considered in the realm of a child abuse type red flag. The other red flag that we think about is location. And so typically with forward momentum, we will see that kids that are up and about and ambulatory will most often sustain bruising on the front part of their body because that's where our momentum is. And also, it's less common to see bruising in areas that have a lot of padding. And so when we think of those areas, we think of the cheeks, we think of the buttocks, and then also I explained it with, we would typically see bruising on the front of the body. So the opposite of that would be that we would be worried about bruising that we see on the back of the body. Again, these are red flags and they do not make a diagnosis of child abuse, but they certainly merit giving consideration, slowing down, and thinking about the case in a really critical way. Next slide. This is an acronym that it has evolved over the years. It first started as the 10-4 rule, and then it became 10-4 facies. And now we've added a P to the end of it. So just to keep in mind, this is almost like a summary of the red flags that I mentioned before. So you can read through. We have a couple of locations that would be considered concerning for child maltreatment. The torso, the ears, the neck, infants who are not yet cruising. The frenulum would be the pieces of tissue that are in a person's mouth. They join the top and bottom lip, basically to the gum line. And there's also a frenulum under the tongue. The angle of the jaw, cheeks, we mentioned already, eyelids. Subconjunctival hemorrhages are red areas of bleeding on the whites of the eye, and patterned or clustered bruises, which we identified on the previous slide. So there's a bit of a summary there to refresh on the bruising red flags, and also some specific features of the bruising. So not on the front of the body, usually unusually large or numerous, and also don't fit with the mechanism described. And we'll see this when I present a case, which I think is coming up. So we'll keep that in mind. Next slide. So just a few examples here. So when we think about our red flags, this one would ring off for me because of the location on the abdomen. This is a pattern, this is a protected area with subcutaneous tissue or some soft padded tissue overlying the belly. It's also a relatively protected location. So that would be another pause for me to sort of think about this bruise a little bit more critically. You also might be able to appreciate a pattern to this bruise in that it sort of gives the impression of two semicircles that are facing one another with an area of clearance in the middle. And we often see that pattern when bruising has resulted from a bite. And so that I would suggest to you that there is a pattern to this mark, that it's in an atypical location for bruising. So a number of red flags. Next slide. Again, here we can look at the location. So this would be on the back side of the arm as opposed to the front. There also seems to be a pattern to these marks. potentially suggestive of the outline of some fingers that we might see. And again, there would be some red flags to this bruising that I would not say would be routine or typical. Next slide. Again, here there's extensive bruising that we can see on the cheek. And this would be one of the locations in the 10-4 rule that I put up earlier. The bruising also is fairly extensive, and then it goes all the way from the cheek onto the ear. And I do see that there are some lines contained within the bruising, and those might be the outline of fingers. In this particular case, putting everything together, I would be worried that this child had been slapped, and that we see some outlines of the fingers, and that the fingertips likely would have extended onto the ear. And so that's why you see bruising all the way from the angle of the jaw all the way to the ear. I think Tanya wants me to speed up because she changed the slide. Here on the ear, again, thinking of our 10-4 rule, would be a very atypical area to see bruising in a child. Not impossible with kids that are playing with toys, etc., but certainly should give you a little bit of pause to try and understand how this bruise may have happened. Next slide. Here we see extensive bruising. Again, the soft tissue of the bum would be an atypical location for bruising just from accidental trauma. This bruising extends nearly halfway down the thighs onto the outer aspects of the thighs, so would be very concerning in terms of location, in terms of pattern, and in terms of extent. Next slide. So I'm going to go through a case here. A 7-month-old female is involved, and a mom received a text message from the daycare that the baby was noted to have a mark on her face because she had hit her own self with a toy giraffe. The mom picked the child up and was quite worried about what she saw, so she took the baby to the hospital for an assessment. It was reported to the Children's Aid, and a joint investigation was undertaken. So this is the photo of what was originally seen. You could appreciate why the mom had some concern. This was reported as an injury that the baby had inflicted on themselves. Again, extensive bruising going all the way from the cheek, our high risk area, all the way up to the outer aspect of the eye. Next slide. This baby had had 2 previous bruises in the care of this babysitter that had happened over the last little while. One had been recently, and again, the story was that the baby had hit herself with her own rattle. The medical history for this little gal was unremarkable, and there were no other bruising concerns that the family had reported or bleeding concerns, and that history was explored. Next slide. When the child was seen at the CAC, we can see that the marks had really improved a good deal. So these marks will not be present for weeks on end. So we do need to arrange for an examination, not within hours, but certainly within days. But you can still see, keeping in mind the image from a few slides back, the bruising is in the same area, and it's resolving in a differential way. So some parts, the skin almost looks back to normal. And in other areas, you still see some red and some purple and some yellow. Next slide. This child, because of the age, did have a skeletal survey that was done. There were no extra injuries, and they did undergo medical testing to see if there potentially could be an underlying bruising or bleeding problem. That was normal. And head imaging for this baby was also normal. Those studies were undertaken because of the baby's young age. So there was a case conference that occurred, and we put in brackets there the alleged offender. that the police had obtained was brought to the meeting. So there were different weights and measures that were taken. It actually was quite a light toy. It was almost hollow. And there were interviews that were conducted with the babysitter just to make sure they had a clear timeline of the injury events. And so essentially the outcome of this case was, this was very concerning for inflicted injury due to the extent of the bruising and the suggestion of a pattern. Also, the developmental stage of the child was felt to not be compatible with a self-inflicted injury. The initial photographs had a typical appearance of application of force with a hand or an object. And then the follow-up photographs, although they couldn't add to that opinion, they certainly were in keeping with where the original bruising had been. So that home daycare was closed. This is a case from a while ago, but I do not believe that criminal charges were laid. And it really showed a nice collaboration between the medical process and the investigative process.
So some of the logistics that tend to come up when we're talking about the medical team and the investigative team at a CAC, some things like a child who's at the school with an injury, and how does that child get to the CAC or the hospital? You know, who's transporting them? How do we get consent? Should we be taking the child into a place of safety first? And, you know, getting the medical team sort of making decisions about an injury prior to coming to see a medical provider, we often discourage. So when we hear things like, oh yeah, the story sounds reasonable, I don't think they need a medical examination, what we're really trying to encourage is that the medical providers should be the ones who make decisions around injuries and whether, you know, what the injury has possibly been caused by, provide an opinion. So again, really encouraging the multidisciplinary team to reach out, consult, and allow the medical provider to triage that case appropriately. I'm just cognizant of the time, so I think what I'll do, Atika, is just open it up for questions at this time.
Absolutely. If you want to just go over your summary, we have a couple of minutes. We only have one question at this point.
Okay.
So why don't you go ahead and conclude your summary, and then I will ask the question.
Sure. So our summary is really that for all cases that are being investigated through a CYC, they would all benefit from a comprehensive medical evaluation. That collaboration between the medical team as well as the investigative systems is very critical and should happen as early as possible in terms of the investigation. And to always call and consult with a designated medical clinician through the CAC, again, so that timing, where the child should be seen and who the child should be seen by can be established.
Great. Thank you, both Tanya and Amy, for that presentation. We have one question. At what age can a client have a support person with them during the physical exam after sexual assault?
So there really isn't a specific age. I think what we typically do is ask the child or the youth who they would like to accompany them into the examination. I would say, though, generally speaking, that obviously toddlers and school-age children tend to want their parent or caregiver in the room with them. And for adolescents, even young adolescents, I typically at least start with meeting with the adolescent alone. And then when it comes time to doing the examination, I always offer to see if they would like to have a support person or someone with them during the examination. So I wouldn't say that there's like a hard and fast sort of specific age, but that's generally sort of what I typically see.
Great, thank you. it doesn't seem like we have any other questions. For the participants, I have posted the contact information for both Tanya and Amy in the chat box. I will do that again just before we conclude here. So if there are no other questions, that is our presentation for today. Thank you so much.
Thank you.
Thank you.